Welcome to part 2 of pain. We're going to talk about assessing a person who has pain. When it comes to assessing our patients in pain, the first thing we need to remember is that pain can be considered a vital sign. We should be asking about pain whenever we're assessing our patients and whenever we do vital signs. If we see our patient every hour, it would be best practice to ask them if they have pain every hour. There are many reasons why we want to assess someone's pain frequently. First, if we ask them about their pain frequently, patients are more willing to report their pain. And if they report the pain, we can treat it and they'll have pain relief and they'll have better satisfaction with their care because nobody wants to be in pain. We must assess their pain before we treat it. So secondly, if we assess it frequently, we're going to treat it more frequently, which means we're keeping the pain medication in their system. So they're going to have a better therapeutic effect. So we actually end up using less pain medication, which means we're going to manage their pain better. Third, assessing for pain frequently can help us identify any pathological conditions or procedures that may be causing the pain. Fourth, people whose pain isn't well controlled are less able and willing to do their ADLs. They don't want to eat, they're not going to heal, and pain just increases the risk of complications. Think of a time that you had pain. Did you want to get up and move around? Did you want to eat? Did you want to drink? Now imagine you're a patient who just had surgery and you're in pain and you don't want to move, which is going to make you at risk for skin breakdown. Not moving makes you at risk for pneumonia, and they don't want to take deep breaths or cough, so they're at even higher risk of pneumonia. They don't want to eat, which means their wound healing is going to be delayed. When we assess pain, we need to make sure we assess each part and each aspect of pain so we have the most data we can. One way to help us remember everything we need to ask is using the PQRST acronym. It's not a requirement to use it. It's not something that all nurses use, but it's a great way to remember to ask everything. And I have seen a lot of computerized documentation set up in the PQRST method to make sure that we are assessing all aspects, which is really helpful to us. So what does each letter stand for? Well, P is for provocation or palliation. So kind of giving us some information of the pain. When did it start? What were you doing when the pain started? What caused it? What makes it better? What makes it worse? What's triggering the pain? Is stress making it worse? A position, certain activities? And what's relieving the pain? And what have you tried? Have you tried medications, massage, hot or cold, changing position, being active or resting? And then what aggravates it? Moving, bending, laying down, walking, standing, what's making it worse? The Q stands for quality or quantity. What does it feel like? Use words to describe the pain, such as dull or sharp or stabbing, burning, crushing, throbbing, nauseating, shooting, twisting, stretching. Like, how does that pain feel to them? And then R stands for region or radiation. Where's the pain located? Does the pain radiate? Where does it radiate to? Does it feel like it travels or moves around? Did it start somewhere else and now it's localized to a different area? S stands for severity scale. How severe is the pain on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain ever? Does it interfere with your activities? How bad is it at its worst? Does it force you to sit down or lie down or slow down? How long does the episode of pain last? I will say that this part of assessing pain can change depending on the population you serve. Kids and babies have a different scale than adults, and some people may be able to answer, is it severe, excruciating, moderate, or mild, easier than a 0 to 10 scale. We can ask if the pain is affecting their quality of life or their ability to do their ADLs. And then T stands for timing. When or at what time did the pain start? How long did it last? How often does it occur? Is it hourly, daily, weekly, monthly? Is it sudden or is it gradual? What were you doing when you first experiencing the pain? When do you usually experience it? At day or night, early morning? Do you ever get awakened by the pain? Does it lead to anything else? Is it accompanied by other signs and symptoms? Does it ever occur before, during, or after meals? Does it occur seasonally? When we assess a person's pain severity level, especially for adults, we usually ask what their pain is on a 0 to 10 scale. 0 meaning no pain and 10 being the worst pain ever imaginable. Now this can be very subjective and you will get answers like 50 when the scale only goes up to 10. Sometimes using a visual aid like these on the screen can help a person understand the scale a little bit better, and sometimes we need to educate the person better. I always say 0 being no pain whatsoever and 10 being the worst pain you could ever imagine, like a bear is ripping off your arms and legs. Even with that, I'll still get answers that are off the chart. One thing to ask when asking about their severity is what number of pain is acceptable to you? So if they say their pain's a 4 and that a 4 is acceptable to them, they may not require any pain medication. If they say their pain is a 4, but their acceptable level is a 0, we're going to have to do things to help relieve their pain. If someone says their pain is a 5, so halfway on the scale, this is considered moderate pain, and this is when I personally want to intervene and start treating their pain. I don't want to be treating their pain when they're a 6, 7, 8, or 9, because to me, that's too much pain for a person. I want to catch their pain at a 5, and I should be able to if I ask them frequently how their pain's doing. This is the Wong-Baker Faces Scale, and it's typically thought of and used with kids. Kids are really good with pictures, but if you noticed on the last slide, those adult pain scales are really a combination of numbers and faces. That's because some people are better with pictures, and seeing a picture of what they feel like may help them communicate their pain better. So Wong-Baker can absolutely be used for adults and even adults who are cognitively declining, like our elderly. And as an FYI, different nursing specialties do have different pain skills that they use. In the ICU, if the patient's intubated on a ventilator and can't speak, they can't rate their pain for us. So the ICU has their own pain scale to help us with that. And as you find your place in nursing as a new grad, you're going to learn which pain scale is best for you and your patient's population. So pain is a very subjective problem. We're asking the patient to give us information about their pain. They can say anything they want, but sometimes we can have objective, measurable data to show us that the patient is having pain. And I want to say, the lack of objective pain measurements does not mean the patient is not in pain. Do not let the lack of objective pain measures fool you into thinking the person doesn't have pain, because that is not true. So some of the physiological objective pain signs we may see include changes to their baseline vital signs. Remember that pain can set off the nervous system and people go into that fight or flight mode, that sympathetic nervous system. So we can see an increase in pulse rate, respiratory rate, and blood pressure. They'll get diaphoretic, sweaty, and pale. Their pupils can dilate and their face and body muscles can get a lot of tension in them. That's where we see the clenched teeth, frowning, fetal position, clenched fists. People may become nauseous and they may vomit when they're in pain. Some behavioral signs of pain we may see include restlessness, frowning, those clenched body parts again, crying, moaning, pacing, even refusal to move or move a body part. People can become angry and hostile when they have pain. Some people, depending on their culture or beliefs, may even have spiritual crises when they have pain because they believe that pain is a punishment or a sign from higher powers or even karma getting back at them. When we do our pain assessment, it's incredibly important to remember to accurately document the pain. We need to document all of the objective and subjective data we found, of course, but we also need to document the person's understanding of the pain scale, especially if they're rating their pain off the scale. We need to document the patient's satisfaction with their pain level and with the current treatment modalities. Ask the patient what his or her pain level is prior to taking the pain medication and then what it is after taking the pain medication. If the patient's pain level is not acceptable, what interventions were taken? Document if they worked or didn't work. We need to make sure we do a timely reassessment following any interventions and responses to treatments. Quote the patient's response. We do such a poor job of evaluating patients, and pain is no different. Cerner actually had to build in a task for us to go back and evaluate our patients after we gave them pain medications to force us to evaluate our patients. That's how bad we are. We need to document any communication with the provider regarding the pain, and we always need to report any changes in condition. We need to document the patient's education provided regarding pain, pain medication, and any other treatments we did to treat the pain, and document their response to their learning. Don't write patients understands without supportive evaluation, such as the patient can verbalize, they can demonstrate, they can describe, etc. And this is the end of part 2 of pain, assessing pain.